In this edition of For Your Health, we're being joined by Dr. Magdi Mylad. He is, listen to this title, he is the Chief of Gynecological Surgery at Northwestern Memorial Hospital and Medical Director for the Center for Comprehensive Gynecological Abnormalities, or what would be normal. And it's interesting because I know that there are plenty of people listening to us who are women or who love women and are concerned about all kinds of things that happen when you hit certain ages, when you're younger, etc., especially when it comes to hysterectomies. There's a lot of conversation about that. So, Doc, thanks so much for coming on. Appreciate it.
Thank you, Kate, for having me.
So here's the thing. When we talk about chronic and painful gynecological conditions, I read a staggering statistic that by the time American women are 60 years old, 1 in 3 have experienced some type of pelvic health disorder. Wow. And how many don't realize what's going on? And there's a lot of confusion, right?
I agree with that. Yeah. And I think it's a common scenario is that women sort of put it off. You know, they've got a lot of things going on, a full plate in their life, and it potentially just gets worse and worse to the point where, you know, it's so far gone, it's not that easy to sort of reverse.
Yeah, and one of the things I mentioned is hysterectomy, and I've certainly heard that from a lot of people in my neighborhood. I was just playing tennis with someone, and they were talking about complications from a hysterectomy, so it's
right.
So timely that you're here on this show. And explain hysterectomies and the alternatives to hysterectomy.
Sure, yeah, hysterectomy is defined as removing the uterus surgically. There's a partial hysterectomy, which is where we remove just the uterus and leave the cervix. The cervix is where we do a pap smear. So in a woman that undergoes a partial hysterectomy, they still need pap smears until they're 65. As long as they stay normal, then they can stop. A total hysterectomy is where we remove the uterus and the cervix. Oftentimes with hysterectomy, we'll also remove the fallopian tubes. We think that removing the fallopian tubes may lower the risk of ovarian cancer in the future, which seems like kind of a crazy thing, you know, taking out the tubes reduces the risk of ovarian cancer, but we think those cells from the tube may seed the ovary and put patients at risk for ovarian cancer in the future. So if we're doing hysterectomy, we do remove the fallopian tubes oftentimes. But hysterectomy is done very commonly. Yeah, it's done, you know, 500,000 hysterectomies done a year. A lot of those are outpatient. They can be done as a small incision, laparoscopy or robotic or vaginal, but we're probably doing too many of them. I think a lot of women can be managed medically, either hormonally or non-hormonally, or using a procedure of some sort, some other thing short of hysterectomy, and hysterectomy should be only in the extreme.
So it's interesting because, as you said, a lot of times women put things off, then you get that chronic pain, then you hear, oh, I have to have a hysterectomy, then the panic sets in. So what you're saying is it'd be a good idea to really look around and talk about some of these alternatives, because there may be a way to treat it instead of going the surgery route.
Right, yeah, for sure. And I think when, you know, with like other complex chronic conditions, it's really important to approach it in kind of a multidisciplinary fashion. So just like if you had, I don't know, rheumatoid arthritis, you might not just see just one provider. You know, you might see multiple different types of doctors and other caregivers, so that you have a sort of like a different perspectives to the same disease. So we've tried to design our clinic in that fashion, so that it's a multidisciplinary experience, so that when patients leave after a single day, they have some answers and can take that home. You know, so they see, oftentimes if they have fibroids, they might see a gynecologist, but they might also see an interventional radiologist, so that at the same visit, they can get opinions from 2 different disciplines, 2 different providers, and be able to come home and say, yeah, I need this or that. This makes more sense for me. This is how I want to prioritize my symptoms, you know, whether it's bleeding or fertility or whatever. Same with pain. Patients that have pain, we have patients see a counselor. We have patients see a physical medicine doctor. We have patients see a physical therapist, a doctor that can do hormonal therapy, and a doctor that can do surgical therapy, so that they have this like multifaceted approach to the same chronic condition, and they can sort of design a protocol or a treatment plan that makes sense for them.
Yeah, wow, listening to this, we're speaking with Dr. Magdi Mylad, and in this vision for your health. What I love what I'm hearing, Doc, first of all, I can hear your passion coming through, and I love comparing rheumatoid arthritis so people really understand that. But it's collaboration. So you're saying, like, in your practice, the power is in the collaboration with other ways you can treat something, or a couple of different ways to treat something to give the woman the best shot of really having just a great experience, right?
Yeah, absolutely. I think that's critical, and it's unusual that we have it all in the same center. You know, on the same office, we have all of these different providers. It's not easy to sort of set it up that way. There are a few places in the country that are doing it, but it's the rarity. More typically, patients will go see their general OBGYN, and then from there, they're referred to one person, and they go to that office to make an appointment, and so on. They sort of get distributed out and come back again, and back and forth, back and forth. In our office, we all sit in the same place. So the patient goes from office to office to office within our center, all on the same floor. And then before they leave, they have opinions from all of us so that they can go home and sort of think through what makes the most sense for them. So I think that's number one, is that sort of that one-stop shopping. And the second thing is that this is all we do. So, none of us deliver babies, and none of us do annual exams, and none of us are doing pap smears. And like, all we do is focus in. So you get pretty good at, being an expert in that one specific line. Half my patients are patients with fibroids. I think having someone who's like an expert in that one thing, just like any other thing, you get really good at it.
Yeah, and you say 3 out of 4, or some of the statistics I've seen, 3 out of 4 women will have one or more uterine fibroids at some point in their life, and it's like endometriosis too as well. It's something that people get confused about, and 1 in 10 women have to deal with that. So it goes back to the whole fibroids, et cetera, and dealing with that. And would you say it's just critical to not wait? Because it seems like a lot of people wait and then a condition gets worse.
Right. I think that's very concerning. Yeah, I think it's very easy for women who are super busy and trying to juggle multiple missions, and that they sort of put things off, and as a result, things just get worse. And so, I think you want to be really aware of that this is interfering with my quality of life. Make sort of admit to yourself that I can't be intimate, I can't exercise, I can't be at work, like whatever it is that you can't do, this is important, and it's resolvable. I worry about women who sort of let it go, and then they, now things are sort of like so far out of hand that sometimes therapies don't work. If fibroids get to be the size of like a full-term pregnancy, we have less options. We have less options. I'll admit that.
Yep, I'm glad you said that. So we talked a little bit, you mentioned hormones, you talked about therapy there. What are some of the other latest advances for women with these chronic gynecological conditions?
Yeah, so fibroids, the embolization has been around for 20 years, but now they've got it to, perfected. It takes like 30 minutes to cut off the blood supply to fibroids. It's an overnight stay and back to your usual stuff within a week. It's just amazing. And nowadays they can actually go through the arm, not the leg anymore. So about half the time they're going through the arm blood vessel. So there's no restrictions as far as activities afterwards. So that's a big one.
Wow.
There's new drugs that are out for pelvic pain and endometriosis. I'm sure you've seen the advertisements, but these tablets are act right away compared to our other drugs that sometimes take a little while to sort of ramp up. I've had young women in their 20s that were just demanding a hysterectomy. They were just at their wits' end with pain and interfering with their life. And within a few days of starting these new drugs, they were like, I'm a new person. So that's out there. There's probably a new drug coming out. There's new protocols that are coming out, sort of experimental protocols for fibroids and adenomyosis, which is a condition similar to endometriosis that causes painful, heavy periods. And then finally, there's a new drug coming out probably next year or so that's already available in Europe that potentially could be used for maintenance. So you could potentially, a woman could sort of go on a drug and then come off of it and sort of keep those fibroids or endometriosis in check until such time as things change. Maybe they want to pursue a pregnancy or whatever it is. So all kinds of new things happening in this realm.
Yeah, it's a good thing to look for. Hey, we have like a minute left, and we're going to send people to where they can go for more information. But tell us about Northwestern's gynecological surgery program.
Yeah, I mean, I think Northwestern is really committed to women's health. And so, we've had a women's hospital here for decades. They just built a new one about 10 years ago, Prentice Women's Hospital. So it just tells you like how they prioritize women's health. And they've done the same thing for gynecology as well. So the top floor of the brand newest building on campus is an entire floor of women's health. 1/3 is for fertility patients, 1/3 is our procedure room, and then the other third is our Center for Comprehensive Gynecology, as well as our Center for Sexual Medicine and Menopause. So it just tells you how it's prioritized. And like I said, it's a one-stop shopping with experts that this is all they do. This is all we do is pelvic pain, endometriosis, fibroids, and it's a great place to just get a second opinion to make sure you're on the right track. Maybe what you're doing is exactly what it should be, but just to get a second opinion.
Oh, that's such good news to hear that, getting the second opinion, definitely. So we'll tell everyone to go to migs.nm.org for more information. Dr. Magdi Mylad, pleasure to talk to you. Thanks so much for coming on.
Thank you for having me, Kate. Thank you.